I want to introduce our next speaker, and it's Dr. Clive Peedell, who is an incredible gentleman in his own right, because he's actually an English politician as well as a radiologist. Who knew that you could do both things? So Dr. Clive Peedell, he's a consultant clinical oncologist at the James Cook University Hospital in Middlesbourgh. And so he's going to come and take us through the history of radiotherapy, and it's really fascinating. Well, I think it is. So anyway, over to you, Clive.
Thank you so much. Well, that was really hard to follow. I hope you can hear me. Is that okay at the back there? Deborah, thanks so much for inviting me and your committee. You've done amazing work. I know how much behind the scenes you put into this, and it's a real pleasure to come and speak to you all today. Sorry about my voice, a bit husky. I was fortunate enough to be at Twickenham yesterday to cheer on the Red Roses. Really give them a well done, girls. Yeah, absolutely wonderful. What I thought I'd do is give an update in radiotherapy, and I'll just give you a quick overview of what I'm going to talk about today. It's quite nice just to go into the history of it, really. It's really quite fascinating, and see how many advances that we've made over the years, because, you know, this is actually quite an uplifting story to see this. I'm going to talk a bit about what we call SABR, or stereotactic radiotherapy. And that's particularly important in lung cancer, both in the early stages of diseases, but also in the advanced stages of diseases, and also in what we call oligometastatic disease, which is quite relevant to the ALK community with all these fantastic drugs, because when eventually, you know, if the disease does become resistant and it's isolated, we can go after it either with surgery or radiotherapy. So it is, you know, becoming increasingly important to understand about the role of radiotherapy in this disease. So I'm going to take you through all the different stages, from early stage through to sort of metastatic disease and palliative treatments as well. So what is radiotherapy? So basically it's the practice of using ionizing radiation to treat cancer, malignant disease. Interestingly, we can treat a few benign diseases as well, but it's basically to treat cancer. And in general, we're using electromagnetic radiation, X-rays, although sometimes we can use particles like electrons. Sometimes people might have heard of proton therapy, which is slightly different. We can maybe come on to that right at the end. But basically, it's using X-rays to treat cancer. And the way it works is it damages DNA in cells, and it basically splits the DNA into pieces. There's two different types of damage. One is what we call the double strand breaks, and that's the most important type of damage. If you get the double strand breaks, it can't repair itself, and the cells die off. If you get the single strand breaks, then DNA is a template and it can repair. So it's really important to get the right doses in order to get the damage that we need. But obviously, if we're killing cells, we're also killing normal cells, and therefore there are toxicities, and we'll come onto the importance of that in a second. About half of all cancer patients are going to need radiotherapy at some point during their illness. It's a key part of the multimodality modern management of basically all the type of tumours that we see, and we use it both in the curative setting, the adjuvant setting, so sometimes give it post-operatively in various diseases, and obviously in a palliative setting as well. So it's got a major role in all the stages of lung cancer. Some of you recognise this gentleman. This is Röntgen, Wilhelm Conrad Röntgen. He actually discovered X-rays in his lab in 1895 in Würzburg. He was basically working with these sort of Crookes tubes at the time, and one of them was in a box, and which was a black cardboard box, and he turned the machine on and he noticed a screen at the other end of the room started glowing. It had a phosphorescent type of paint on it, and he said, wow, something's going on here. So we then started putting various objects in front of it of different thicknesses, and worked out actually that something's blocking these rays. So what any good husband would do, he got hold of his wife's hand, and then he put that in front of a photographic plate and took the first ever X-ray of a human hand there, and you can see a wedding ring there. I don't know how long that lasted for, but so that was the first ever X-ray. And remarkably, within a year, this is when there was no regulation whatsoever, because a medical student did some radiotherapy to a breast cancer patient in 1896 in the United States. And actually the tumor responded. The patient died of metastatic disease, but that was the first radiotherapy by Gruber in 1896. This was one of the first diagnostic X-rays actually used clinically and showing a Colles fracture. If you can see the fracture, good luck. But it's actually got a cast. Patient's got the cast on there. But that was in 1896. So you can see there was a discovery of X-rays in 1895, and they're using them in diagnostics and treatment within a year. It's quite remarkable. And even using them in the battlefield. So they had X-ray units in the British River Wars on the Nile. And then at the same time as this, the Curies and Becquerel together discovered radium. And so radium comes from pitchblende. And Pierre Curie had a little sample of it, and he put it in his top pocket. And after a few months, he had this radiation ulcer developed. And they thought, wow, this is having an effect as well. So they did a huge amount of work. In fact, Marie Curie, she got a Nobel Prize in both physics and chemistry, the only person ever to have got 2 Nobel Prizes in different subjects, which is another remarkable lady. And unfortunately, she died from aplastic anemia. So all that work she did eventually caused her demise from radiation-induced aplastic anemia. So her bone marrow stopped working, basically. She died at the age of 66, and all the research papers remain radioactive. This is one of the early radium treatments. So this was like a superficial therapy. So you put some radium on the end of basically a long-range stick, and then press onto where the tumour is. And this is an angioma that was treated, one of the first ever children that was treated by radiation, again, about 100 odd years ago. And not surprisingly, the media got hold of all of this, and there was a huge explosion of the use of X-rays, but for both good and bad purposes. People were just setting, because it was so easy to set this equipment up, they were basically making their own kit, and it became available. And not surprisingly, lots of charlatans were coming out of the woods, and there was a lot of a hysteria around it at times. So that was Thomas Edison. He produced a home fluoroscopy kit, and people thought it was really cool because they could look at their relatives' sort of bones through the cameras. That's not very good for your eyes, that, when you're doing that sort of thing. You can go blind. And the other thing that was happening, people would go down into radium mines because they thought it was really healthy. But they became the spas of the day. Go down 1,000 feet into a mine and you'll be lovely and healthy. And even more, just drink some radium water. It's really good for you. It was remarkable. Why not have some toothpaste? Brush your teeth with radium. And have a nice wash with it as well. And let's actually go out on the town as well. Years ago, it was all the rage to mix it with some phosphorescent stuff, and they used to have glow-in-the-dark champagne in the social scene in New York. Unfortunately, reality began to kick in fairly soon. People were using it, for beauty treatments and getting these radiation ulcers. And the early pioneers would get radiodermatitis, so they're handling all this stuff, and basically it's killing off cells over months and years, and you end up getting auto-amputations. This is radium damage. And a particularly tragic story with the radium girls, they would paint the watch dials with their paintbrushes, and they just licked the end of it so they could do the accurate painting of the watch dials. And unfortunately, many of them got mouth cancers and, again, aplastic anemia. A huge number of these women died. And there's a memorial to all the radiation pioneers in Hamburg, which I just think is really quite poignant. Some good things came out of this, though. We realised, actually, you need to be really careful if you're using these X-rays. And actually, this is one of the really early treatment labs in the 1900s. And you can see this lady on the left has got a mask, and actually this is shielding. That's the first sort of use of shielding, and the importance of shielding normal tissues so you can treat the tumour tissue. And then we got more powerful machines. I mean, these things look like something out of a B movie, don't they? Horrendous type, massive cobalt machines and linear accelerators that were developed. And that one there, and the blue one there, that was actually in Newcastle. It was a Mullard, that was called. I think they've moved on, the Newcastle people. Not quite as good as Middlesbourgh with their departments, but they're getting there. They're catching up with us. But this was one of the linear accelerators when I trained in Cookridge in Leeds in actually in the 90s, but these came along in the 1980s. This one was about 1990 odd, and you can see it can rotate in 360 degrees. What it doesn't have, and what the modern ones have, is actually got a CT scanner on it as well, and probably got a picture of one of those in a minute, so it can actually scan you while you're having treatment, and that's called image-guided radiation. That was really crucial. This is one of the other breakthroughs, and within the treatment head, you could shape the beam. So the X-rays are coming out of the head of the machine, and you can shape it to what the target looks like, and therefore we're shielding normal tissues. This is a prostate being treated, and we're starting to shield areas like the rectum and the bladder, which are the nearby structures. And this is where the image guidance came in. Bolted onto the side of the treatment head is a CT scanner. It can rotate and form an image, a CT image, and you can overlay that with a planning scan. So people come for their planning scan first, then they come for their treatment. If they're slightly out of position, you can literally correct the couch within millimeters. So we've got sort of a couple of millimeter accuracy while we're delivering it. And there's different types of ways of getting the X-rays. That's the CyberKnife at the bottom left, and the X-ray machines in the ceiling there. And then the tomotherapy machine has actually got, you can actually see there's a CT scanner and the treatment machine within the same piece of kit, all in that unit. And this is sort of the ultimate new machine. This is the MRI, otherwise known as the MR Linac. And this is about 8 to 10 million quid's worth of kit. And that's the problem. They're very expensive. A normal linear accelerator costs about 1.8 million. And we have 6 of those in Middlesbourgh. And this allows you to have real-time MRI imaging. And you can see on the bottom left, this patient's actually got a camera to look at, and they can actually see their tumour moving up and down. And the beam can turn off and on when it hits a certain area. And then you can actually coach the patient. So if you want your treatment quicker, just hold your breath when it gets to this area whilst you're inside the beam, and we'll be able to get you off your treatment quicker. And basically, it will allow the delivery very, very accurately to that. So it's quite remarkable. In real time, you can do this. We've also got what's called 4-dimensional CT scans when we do our planning. You know, people who've got lungs are breathing. The tumour moves with breathing. We need to know how much that tumour's moving. And we know from the research that the bottom of your lungs move a lot more than the top of your lungs. So what we can do is we can do motion management techniques. One of them is actually to know the exact volume of the envelope of motion that we're treating. The other thing we can do is actually do abdominal compression to dampen down the respiratory motion. It looks a bit like a medieval torture device, but it does work quite well. But literally, you put a plate on and then just keep screwing until they can't breathe anymore, basically. We don't go that far, but I've tried it myself, and it's actually reasonably comfortable. It can reduce motion by up to 50%, and again, reduce side effects. The other thing we can do these days is we can actually shape the planning of what we're trying to treat. We sort of call it dose painting. So we can now literally get a 3-dimensional volume with what concave volume, so we can wrap around the esophagus. So that little red thing in the middle is the esophagus, and then the spinal cord is that thing in the middle there, and we can wrap the dose around there. So we can literally do what we call dose painting. And just to show you a little fun bit of work we did at James Cook, our physicists, in their coffee break. Got a picture of Captain James Cook there, and they can actually deliver the radiation dose to the picture of his face by shaping the collimators as it's going through. So you build up the dose as the machine's going round, and you can see the way the collimators are going in and out, and that dose builds up, and you can literally paint whatever dose you want inside the patient. So you can imagine if you wanted to highlight an area of tumour, maybe around that left eye region, you give a really high dose there and then spare the normal brain away from that. So that's just an example of what the physics can do. It's absolutely remarkable. And then you can use your PET-CT scan and potentially dump the dose in the hotter areas, and then have the colder areas where your other structures are. So you can even target within the tumour itself and put hot spots of dose where the tumour is most active as well. So these are the sort of things that we're doing. And what can also happen, especially in lung cancer patients, especially if you've got a proximal lesion, in other words, a lesion that's obstructing a main bronchus, you get some collapsed lung. I always teach the registrars, if you imagine if you've got a balloon and then basically you stop blowing into it and you obstruct it, eventually all the air just comes out of the balloon and it sort of collapses down. And what happens in the lung tissue is if you've got a blockage, you've still got a blood supply to the lung, so the blood supply takes all the gas out and your lung collapses. The way to inflate it is to shrink the tumour down and then blow the lung back up and reventilate it. And actually that can happen during your treatment. So this patient down here had obstructed lung, and you can see the lungs all collapsed down here. That grey, that's your heart. That all grey stuff down there is collapsed lung. And the tumour started to shrink with the radiation, and then it blew the lung back up. That's a problem though, because then your whole structure's changed and you're trying to then irradiate something that actually has a different shape to what you were before. But the amazing thing is now we can do what's called online adaptive planning. So literally on the machine, you can re-outline the area that you need to treat, and there'll be an online calculation to recalculate the entire dose, how the radiotherapy is delivered. Like I was showing you, all those little collimators moving in on motors in and out, it has to do all that calculation to deliver that dose. So we can do what's called adaptive planning now. Because in the old days, we'd send the patient, they'd take another 2 or 3 days to restart their radiotherapy because we had to replan the whole thing. So this allows us to be more efficient with our radiation. So we're getting towards the holy grail, what I call it now, of radiotherapy. That's the idea that you're going to give a maximum dose, curative dose to the tumour without causing significant dose to the other tissue structures. And all of these advances I've told you about are pushing us towards this sort of holy grail of radiotherapy to maximise the dose of the tumour with minimal side effects. And this is where sort of the stereotactic ablative radiotherapy comes from. So this is what we call SABR, or also known as SBRT, stereotactic body radiotherapy. It comes from the principles of radiosurgery to the brain. But we didn't do a lot in the body originally because the brain is in a fixed box. That was technically, nothing's moving. It's much easier to treat to high dose. We were worried about doing it in the body because people move, they don't set up in the same position. But with all these new techniques, we can now give these really, really high doses. That's the definition. Don't worry about it too much. I'm involved in this consortium. We call it the precise irradiation of image-defined extracranial lesions with the use of high radiation dose in a small number of fractions. Basically, we give a big whacking dose of radiation in 1 to 5 treatments. That's all you need to know about SABR. It's big doses of radiation. Rather than your 4 to 6 week courses of 20 to 60 odd fractions, we're giving it in between 1 and 5 fractions in selected patients. And this came about because although surgery is the gold standard, and it will be for most ALK patients for early stage ALK disease, because it's basically not completely, but a non-smoking or a never smoking population. So most people with ALK positive disease got really good lungs. So if they've got early disease, they'll nearly always be operated on. But a lot of patients I see, especially up in the borough, are not the fittest in the world, a lot of social deprivation, smoking, heart disease, and they're not fit for surgery. And if they're not fit for surgery, one of the treatments will be you're not getting any treatment in the old days. But they realised if you don't do that, the median survival was about 12 months. And this is for stage 1 disease. So people were dying of lung cancer, not dying of COPD and their other conditions. So we tried to treat them with conventional radiotherapy, but basically conventional radiotherapy doses weren't very good. We're only getting about 40% local control and about a 10 to 20% cure rate. And the reason why is we were not giving enough dose. We were giving conventional doses down here somewhere, so the tumour control probability is a bit rubbish. And even if you're giving 80 gray to get 50% tumour control, these sort of doses we weren't using. You need to be over here, and that is what stereotactic radiotherapy allows us to achieve equivalent doses, 150, 200 gray. So massive doses of radiation. And we've had the first phase 3 trial that has proven that it is, you have a higher cure rate with stereotactic versus conventional radiotherapy. That's the Chisel trial. So stereotactic radiotherapy is now the standard of care for stage 1 to 2 disease, early disease, if you're medically inoperable. So I'll treat tumours up to 5 centimetres, maybe even bigger sometimes. I'll treat tumours that are into the chest wall even. We can treat more central tumours now. Patients, basically, if they're fit for a PET scan, they can have radiotherapy, stereotactic radiotherapy, because it's very well tolerated. This is our setup. The patient comes and we'll set them up in these vac bags. I basically tell the patient, look, imagine a big bean bag. We're going to lie you on a bean bag and then we're going to suck all the air out of it, and it forms a stiff mould around you. So it's literally a cradle position. So that is going to hold for the number of days that are having treatment, and they're just in a nice, comfortable position. This particular patient needs abdominal compression. Only about 10% need abdominal compression. Most tumours don't move that much, and it's a reasonably comfortable position. And that's just showing the 4D scan. We mark out the volume that we want to treat, and then we can apply the dose. And what we're doing up in Middlesbourgh now, for selected patients, I will give a single fraction now to some of my patients. We call that radiosurgery. So one single shot. Most people get between 3 and 5 treatments. But patients really going to say, wow, am I just coming for one treatment? You're just doing one. So absolutely. So I've said to the surgeons, I want to be an honorary surgeon now. I'm a radiosurgeon, so let me join your college. They don't like that. And this is how cool the machines are. So basically, once you come for your treatments, you'll be on the couch. We've targeted this tumour, but the tumour is quite close to the edge of where I want it to be. It's sort of poking out the side, one of the sort of spicules. And so what the radiographers do, they press a button, a bit more complicated than that, but they do press a button actually, and the machine adjusts. So the target moves and you can zap it, So this is why we're so accurate. We can give treatment within a couple of millimeters. Then that allows you to shrink your margins for error, and when you shrink your margins for error, less volume of normal tissue surrounding. Therefore, that's why we've been able to escalate these doses over the years. So we're now looking at it's become so effective. We get about 95% local control now. So in other words, if you zap one of these tumours, less than 5% are going to relapse locally. If they're going to relapse, it's the same problem the surgeon's got. If you remove the cancer, there can be microscopic disease knocking around and it can come back. But in terms of what we call a success is, have we got local control? And if you're getting 95% local control, that's where the surgeons are. A wedge resection, they've got 85% local control, whereas a lobectomy is more effective when they remove the whole lobe. But we're getting quite close to them. So there's ongoing randomized trials comparing surgery to SABR in some of the higher risk surgical patients. We'll be getting this data in the coming years. So some of these studies are nearly fully recruited. So we're excited to find out that data. This was a randomized trial that didn't complete, but they kept going with a cohort study. This is MD Anderson, big cancer center in the United States. And basically, you can see this is incredibly high survival rates. This is in operable patients. So the previous survival curve I showed you was not as impressive as that, but that's because they're treating patients with very bad cardiac and lung function. These are fit patients that we're treating, and look, we're getting the same outcomes as the surgeons with radiation therapy. So no knives, no blood, no anaesthetic, just come and have a lie down. And I say to patients, just have a quick nap while you're having your treatment. As long as you're nice and still, that's fine. Then you can go home. So it's great. So who do you want your treatment with? This is my mate Joel, who's one of our surgeons. Do you want him coming after you with that thing, with his VATS implement? Or do you want your nice oncologist that cuddles old ladies? I mean, who do you want your treatment with? And Joel can't even stay awake. He's asleep half the time. He is a wonderful, wonderful surgeon. We're so lucky in Middlesbourgh to have amazing thoracic surgeons. This guy's amazing. He's actually one of these sort of polymaths who does all sorts of stuff into research, and he can even unicycle. So he's a fantastic, crazy guy that we all love. We're very accurate in terms of our treatments, but as with everything, people go a bit too hard, too fast, and they do the research. But that's the amazing thing about research, and that's why I'm so thankful for patients going into research studies, because they are, sort of trailblazing for future generations. And unfortunately, when we tried to treat the very high doses to the ultracentral tumours, there were a few, deaths from the clinical trials, what we call grade 5 toxicity. And what was happening is, if you give too high a dose to central structures, that's the bronchus there on a bronchoscopy, it was fibrosing. You were getting scarring and then literally completely closing off the lung. So you get complete lung collapse. If you get complete lung collapse and you've got really bad COPD, that's like having your lung out. And, obviously they weren't fit for an operation, and essentially we've collapsed the entire lung. So some patients initially ran into problems. However, the techniques have been refined. We give slightly lower doses for central tumours. It's much safer, and we can now give what we call risk-adapted radiotherapy, and we can get like 80-90% local control for central tumours as well. So it's now standard international guidelines. We give 5 to 8 fractions, so we just split the dose up a little bit for these patients. And then we can go even more right in the middle of the lung as well. They've done the Sunset trial in Canada that shows safety for supercentral disease. And we can even use it for people who've got interstitial lung disease, who've got very, very bad fibrotic lung disease, because they have a lot of toxicity. But in some patients, we can treat them safely as well. What about stage 3 disease? So that's what we call locally advanced lung cancer. So stage 3, basically think about it, it's involving the lymph glands in the center of the chest. But there's a whole different spectrum of disease. It's a very heterogeneous group. So basically, you could have what's called a T4 lesion, so it's involving the trachea and no other spread. And so the lymph nodes may be negative. And at the other end of the spectrum, you might have a tiny little peripheral nodule right at the base of your lung, but have a lymph gland in the center of your chest, and that's stage 3 as well. So this is massively heterogeneous. But because it's more advanced, the cure rates traditionally haven't been as good. And, you know, when I first started, I used to tell my patients, so I've been a consultant 21 years up there, and I used to say, look, you've got stage 3 disease, you've probably got about 15% of 5-year survival. So I basically call that cure if you get to 5 years. But since then, we've had PET-CT that can more accurately stage our disease. And then we've combined the radiotherapy with chemotherapy, and we got up to 30% 5-year survival. So, you know, that's a big increase, doubled. And we've gone even further now. This shows one of the concerns, though, is that people were not treating stage 3 aggressively. So the blue lines are people are treating stage 3 aggressively, percentage, and then the other lines are where it's just given palliative intent. And this sort of shocks the community, because if you've got a 30% cure rate, you're thinking, well, why are you getting palliative treatment when you should be getting radical? And the great thing about BTOG is we really educated the community to make sure that, well, let's push and be aggressive in these patients that are fit enough for concurrent chemoradiation. Let's give them that treatment. And these are the figures that we showed, and we've changed practice, and it's fantastic. And it's particularly important that people get the right treatment. They get concurrent chemoradiation, so radiotherapy and chemo at the same time, because the cure rate's gone up again. Because we now have immunotherapy, not so much in the ALK population, but this is general non-small cell lung cancer population. We've got 43% 5-year survival for stage 3 lung cancer. That is amazing. That's another 10 to 15% jump. You know, when I saw this survival curve, I was like, wow. Normally, when you see a new drug come along, it gives another 2 to 3% cure rate. This is like, you know, 10 to 15%. I say to my registrars, this is like a jaw dropper. This is like a big improvement. We don't usually see, you know, developments like this. And it's the same with these drugs that have come along, you know, the ALK inhibitors and the EGFR inhibitors. They're showing these massive jumps in survival. So it is really, really encouraging to see this. So this was a patient I saw. She got referred from another part of the country because she was moving house. And I had a referral letter saying, can you give this lady some palliative radiotherapy? I mean, she's 40-odd. I think, what are you talking about? You know, this is a PET scan. She's got hot spots in lymph nodes in the top of her chest here and spreading all the way down to the left side of the chest. You see the heart there, so there's just tumour all wrapped round there. That's stage 3 disease. I'm going to treat that radically. I'm going to give you chemoradiation concurrently using all the latest technology. So that was the volume I ended up treating. And then she got a year of durvalumab afterwards. And she's still alive today, free from disease. You know, so she's done amazing. I tried to discharge her. She doesn't want to be discharged. She wants to have a yearly CT, and that's absolutely fine. And I'll scan her once a year for the rest of her life if she likes. Whatever makes her happy, because I like to keep my patients happy, all right? We can have our arms bent, you know, twisted. That's doctors, you know. We're not all like you think. So, and then the next step is obviously oligometastatic disease. And this is, I think, really important for the sort of ALK and EGFR type community because it's not uncommon to get this sort of oligopersistent or oligoprogressive disease. So the drug can work well for many, many years. And then unfortunately, you get a patch of resistant population of disease. And I've got a really good relationship. I mean, I give these drugs as well, but I've got medical oncology colleagues that refer, say, look, this patient's been on, you know, brigatinib or alectinib 5 years, but they've got a nodule. We do a PET scan. That's the only site of disease. So let's treat it. We call it metastasis-directed therapy. another word for MDT, so it's not multidisciplinary team meeting, but we do discuss it there. But and we'll zap them, and sometimes we'll resect them. Usually radiotherapy, because it's completely non-invasive, and we can get really good control rates of these metastatic deposits. So this has been a sort of another big development. There's ongoing clinical trials looking at this, but the early results are amazing, and I just do it as standard practice now. So if patients come up to me, and we'll treat up to 5 metastases. It's all an individual-based decision, depends how technically treatable, but you can treat the liver, the adrenal gland. We can refer up to our local stereotactic radiosurgery up in Newcastle to do the brain disease. So we do that. It's actually a very complex area, so don't worry too much about this diagram, but there's so many different types of oligometastatic disease. So I basically split it up into 3 categories, although like I say, there's about 9 categories. But basically, do you get the metastatic disease up front? Do you get it on relapse, or in terms of you're cancer-free and then the cancer comes back? Or is it never completely cleared and you get what's called oligopersistent disease, where you give the drug and there's still some disease knocking around it? So there's all these different types, but all potentially can be treated. And these are some of the trials. We've had the oligomez trial, named after the bloke who did it, or GOMETS as they called it. And then the Sabre Comet trial as well, that was looking at multiple lesions. And these are very small studies, not huge numbers of patients, but these are sort of like phase 2 clinical trials. But so it's not the highest level of evidence, but this was enough to convince the community. We're seeing significant extra time on these drugs if you give these types of treatment. And these are just some examples. So there's a couple of liver mets we've treated, some adrenal metastases, bone metastases, lymph node disease near the liver. So you can treat basically any part of the body. We're awaiting the results of the HALT trial. This included ALK and EGFR patients, led by Fiona MacDonald at the Marsden. Obviously Sanjay heavily involved in that. You all know Sanjay Popat, who's here at the start of the meeting, I believe. And we're getting some early results as well, not from this trial, but this was only just published the other day, showing that this was more for EGFR patients, but I'm sure it'll be the same for ALK. This was on OSSI. On average, for patients who had oligomets treated, they were on the drug an extra sort of 10 months on average, which is pretty good, considering a lot of patients are still going to, unfortunately, I call it whack-a-mole. You hit one and then another one pops up. But we can keep going after them. I will literally, if it's not too massive a volume, I will keep, zapping wherever I need to, within reason, if it's technically treatable and there's no sign of progression, like multiple progression. Once you get beyond 5 or 6 lesions, it becomes a bit probably not really beneficial and need systemic treatment, really. But it's an individual case-based discussion. We have the Saron trial again. Fiona took over and leading that trial, Fiona MacDonald from the Marsden. That's fully recruited. We might be getting some results next year. And that was upfront treatment of oligometastatic disease. So that's really interesting. That didn't include sort of ALK and EGFR, but it's a really important trial in lung cancer, which is going to take us forward. And obviously another really important area for the ALK community is obviously brain metastases are an issue. Is radiotherapy beneficial? These drugs are so good in the brain that actually there's the role for radiotherapy is actually really quite complicated. Some studies have shown it's useful. Others showed, look, these drugs are so good, actually up front you don't really need the radiotherapy. So there's lots of discussion about the role of radiotherapy. Obviously it's very useful on relapse, but should we give it up front? There's no right or wrong answer to that. The meta-analysis didn't show an overall survival benefit for going up front, but I will take it again. We'll discuss it with the medical oncologist, discuss it at the MDT, discuss it with the neurosurgeons, and we'll take it on an individual case basis. Because you might have a patient who's got a very symptomatic lesion, and actually removing it, if there's a lot of edema around it, may be well worth doing, for example, or giving radiosurgery might be an option. So there's lots of discussions to be had. Again, there's no difference necessarily in what we call progression-free survival between the whole brain approach, or SRS, which is the targeted just to the lesions themselves. But whole brain radiotherapy is much more toxic. It feels exhausting, tiring. So, if you can get access to SRS, it varies how many people will, around the country, but how many lesions people will treat. So my approach is, again, discuss it with your local SRS team. I know some European countries, they treat crazy numbers of lesions. I think this slide, yeah, this is a slide I got off the internet. There's like 34 lesions they're treating. But the evidence base for that is very limited. They will give it as an anecdotal case. Most places get uncomfortable treating above 5 lesions. But it may have been discussed, and I agree that actually it's the actual volume of the lesions that's important, not necessarily the numbers. So they do get nervous above 3.5 centimeters. That could cause quite a lot of toxicity and radionecrosis around the brain. Whereas if you've got lots of small ones, 5, 6, 7, that might be technically feasible to actually treat more numerous ones rather than a really big one. The bigger ones with a lot of edema are probably better resected. And you want to be close to, careful with tumours close to the eloquent areas like the motor strip, speech areas, and things like that. So it's very much an individualised approach, but it's a rapidly moving area, and another really exciting field. Grounds for optimism. And obviously, we do often go into the palliative phases, and radiotherapy is very useful palliatively for obstructive type symptoms, as I explained before. If you've got an obstructive bronchus or the esophagus is blocked, for example, it's good for cough, hemoptysis, chest pain, superior vena cava obstruction, spinal cord compression. So I do quite a lot of this work. This is someone with an advanced tumour in the centre of the chest. It's that thing in the middle, that black thing in the middle strip. That's the patient's trachea squashed. So they've got stridor. They can't breathe. And they've also got superior vena cava obstruction. That little white dot in that grey mass is the superior vena cava being squashed. And they've got all these blood vessels on the outside of their chest because the motorway's blocked. They're all going around the country roads to try and get back. So the blood vessels are on the front of this patient's chest. So they may get some palliative radiotherapy to help with those symptoms. This is a patient with a pancreas tumour. So it's a lung cancer at the top of the chest. Top of the chest is a very tricky area because when you go towards the apex of the chest, if the tumour grows there, it's going to go into structures at the top there, like the brachial plexus, which is a branch of the nerves that come down, because it can be very painful if it involves nerves. And obviously the spine is there as well. You can see the spinal cord, and actually this tumour has eaten through the bone and it's gone in towards the spinal cord, and that can cause spinal cord compression. And the last thing you want if you've got lung cancer is to end up in a wheelchair. I mean, if you can avoid that, some palliative radiotherapy can be very, very helpful in that situation. And this patient went to A&E. Does anybody know what they were complaining of when they went to A&E? They had pain. Where did they have pain? In the back? No, not quite there. No. The hip. Well done. Did you say the hip? Yeah. So you might have mentioned that because basically they've got the hand on the hip. Look, they're in so much pain, like that. They've got hip pain. And their hand was on the x-ray. It shouldn't be there. It should have been taken away. But that tells you where the pain was. And that patient can have some palliative radiotherapy for an underlying bone metastases. That's just when I catch my registrars out with... so you did very well there. You should come and train at our place. Well done. Excellent. And then I'm going to finish off. This is my last case, and on a really optimistic note. This was a lady, I'll remember her to my dying day. She came into my clinic. Basically, her husband saved her life. It was probably about 15 years ago. And a year before, she'd had a lobectomy to treat a stage 1 lung cancer. And then she got referred to me to come to my clinic. By the time she got to my clinic, unfortunately, she was in a dark room and she was just lied down. She was vomiting everywhere and she was just too poorly to treat. And I was gutted because this was the only site of a disease. She'd had a CT scan and she's got this like cystic metastasis in her base of brain with this black dark areas, edema, swelling. And then the MRI shows it in more detail. And I think, crikey, this is the only site of disease. She's too ill to operate on it. It's in a really bad area. I'd love to be able to give some radiotherapy to try and, control this. At the time, we could have potentially referred to Sheffield. That was where the radiosurgery centre was. But she was just too poorly. She was vomiting. She would never lie flat to have treatment. She'd already had steroids for like 24 hours, so I wasn't very optimistic. But I thought, let's just keep her comfortable. We'll get her home. But I did say to her husband as they left, look, we're going to keep you comfortable at home. Get you all the antiemetics. But if she does pick up, give us a shout. And literally 2 days later, he said, he rang up my secretary and I got back to him on the phone. He said, look, I think that she's really picked up. Please will you see her? And I said, yeah, just bring her back to clinic. And she came back to clinic and she looked a little bit better. Still not great, but she stopped vomiting and the photophobia had gone. And I thought, right, let's just, I mean, I don't think I can do radiosurgery. It's a bit big. It's quite an difficult area. That's where your respiratory centre is and your cardiac driving centre there in the brainstem. But let's give some radiotherapy for symptom relief because you still had a lot of headache. So I gave a palliative schedule, 20 Gray in 5 fractions, which is not a big dose, but you can occasionally get good results with it. And she came back to my clinic literally 4 weeks later, and she was right as rain. So I got a CT scan, and that's the difference. I mean, basically, it nearly completely melted away. So she had almost a complete response to palliative radiotherapy. Now, I didn't think I'd given her enough dose, and I thought that's definitely going to come back. So I then sent her to Sheffield for a radiosurgery boost to the residual little area. And then she was great, and I kept her in my clinic. But unfortunately, about 5 years later, she had a lymph node relapse in the chest, PET CT, biopsy, same cancer back again. No sign of any disease elsewhere. So I gave that radical radiotherapy. She then, another 3 years later, had another brain metastasis. So we sent that for radiosurgery. And she then comes back another couple of years later with a lung nodule, which is biopsy-proven cancer. We zap that. And she's still alive today. It's amazing. So, with oligometastatic disease, it's a different, animal, a different biology. And we should always do our very best because you don't know on an individual basis how someone's going to do. So I'm always of the persuasion that if you've got limited disease, go after it, be as aggressive as you can. Always fully informing the patient. Say, look, the odds of this coming back, and I actually use the word whack-a-mole. I say to the patient, look, I could whack this and another one's going to pop up. We use that terminology. It's quite helpful. It really makes people understand that, unfortunately, some people have got microscopic, I call them little seeds, and they can pop up any time, and we'll keep an eye on you. But as long as it's just 1 or 2 coming up, we can go after that. So that's a really important lesson to learn, especially in the, the TKI era. We're seeing this oligo, recurrent and progressive type of disease, and we should really be, aggressive with it, but with full information that we're not giving, ridiculous amounts of hope, but actually some patients can do really, really well, and we need to do that. So just in conclusion, radiotherapy plays a really important role. We've come on a hell of a lot over the years, from dear old Mary and Röntgen all those years ago, blazing the trail. We can treat all stages of disease. Saber's a great new facility that we have, and normal linear accelerators can do this. In fact, we were even doing radiosurgery in Middlesbourgh with a normal linear accelerator and just a plastic shell. But unfortunately, the contract got taken away from us, even though we were delivering very high quality treatment, because they only wanted one centre, which is understandable. You want to focus expertise sometimes in one area. But you can do it with a normal LINAC, and that's what Newcastle do. You don't necessarily need the cyber knife and all those types of kit, the gamma knife. We've got to keep going. Let's keep the research going, get involved in clinical trials. There's lots of research going on. So lots of great things, all the online adaptive. We need some expensive new linear accelerators, please, government. The interaction with all these systemic targeted agents, that is a real area for future research. Combining it with these drugs, doing molecular targeting, and using artificial intelligence. We're already using that. It's doing a lot of our outlining for us. So, but don't worry, the cuddly doctor won't be replaced by a robot. You're okay. And we can give reirradiation. We can retreat areas as well. So it's amazing. So I'll leave you with dear old Captain James Cook, just to show you how awesome radiotherapy is. And thank you once again for inviting me to speak. And all the best. Thank you.
I'm sure you're going to have a few questions.
Yeah, that's fine. Yeah, absolutely. This gent here.
Who has a question for Clive? There we are. This is the first one.
Thank you, Clive, for a very interesting speech and all of the optimism that comes from these technological developments, and of course your dedication and your colleagues' dedication. I don't think there's a yes or no answer to this question. I'm sure it's all case by case, but just on the question of surgery versus SABR. I mean, one concern, well, at least as far as I'm aware, one concern about surgery is the release of cancerous cells which maybe get transported around the bloodstream and perhaps lodge elsewhere in the body and increase the risk of metastases. Of course, that at least appears on the face of it to me that there's a risk that perhaps doesn't exist in the case of SABR. So my question, I'm sure there are no studies on this, but the question really is SABR to be preferred over surgery in some cases?
Yeah, that's a really fantastic question, really, really interesting. Interestingly, there have been some studies looking at, circulating tumour cells, like in operations, and they did a really nice one in breast cancer surgery, and they actually showed, there's lots of tumour cells circulating, around the time of surgery, and thinking, wow, what's going on here? Are literally shells be shedded off? But actually, we know that actually it's an extremely effective treatment. If those cells were to be successful and lodge successful in terms of cancer surviving, then we would see massive relapse rates, and you're seeing cure rates of 95, nearly 100% for really early breast cancer. This is within really small tumours potentially. So basically, even though there are circulating cells around, they nearly always die. They can't survive. So they have to develop over time anchorage mechanisms. So they've got to literally develop proteins that allow them to anchor to wherever they're going to end up, and then they've got to survive there. I sometimes speak to my patients about it, or the registrars. I say it's like going to the moon. You land on the moon, you haven't got a spacesuit on, so you're going to die. Whereas if you've got the spacesuit and you've got all the right kit, so you've got the anchorage mechanism, so you've got there, you've landed safely, but then you've got to try and live there. So that's a really good way of thinking about it, I think. So there are tumour cells that are knocking around, but actually they just never survive, they just die off. And therefore, I don't think surgery would pose an increased risk. So if it's technically doable, fine. My argument against it actually is a different argument, is basically, this is like, we're dealing with patients who've got stage 4 disease. And although we do get some great outcomes, unfortunately, if there's seeds around, there's going to be some other ones. In the majority of cases, it's going to relapse. So why put through someone a big operation who's probably going to relapse and maybe not have a great prognosis, and you've left them in, potentially complications after surgery, less lung function if you've done taken a lobe of the lung out, and when you can just do it non-invasively. So I would just argue for the non-invasive case in that situation, because it's so easy to do, and you get it quick. Just get it done like that. We've got big surgical waiting lists as well. That shouldn't be a major issue, but it is. So if you can avoid delays, just come and have some radiotherapy in general. But there are cases where surgery is a better option. It may be that it's causing a particular obstructive type problem, and you might be able to resolve that problem for them, for example. But yeah, radiotherapy in general is the way forward. And I think the risk of the microscopic disease is not an issue, though. Yeah.
Thank you very much. That was very interesting. I have a question. I have had radiotherapy, and there was some damage to the nerves. So with your lady there, who's had multiple times of radiotherapy, she's living, but with what side effects?
Yeah, that's a really key question. Depending where you treat, obviously, if the tumour is adjacent to a critical structure, for example, I would struggle giving stereotactic radiotherapy to a tumour right next to the esophagus. If you give those high doses to the esophagus, potentially you can put a hole in the esophagus, and then obviously that's not great, because where's the food go? It's going to go into your chest. I mean that can happen. So you have to limit your dose, but you can still get side effects. So esophagitis is a problem in radiotherapy. The chest wall, so if you give very, very high doses of the chest wall, the radiation over a period of time can cause a rib fracture. So you can actually get a crack to the rib. Fascinatingly, though, most of the rib fractures we actually see on a CT scan about 4 or 5 years down the line are asymptomatic. So they had a little rib fracture, they never noticed it, and it just formed a callus. So an asymptomatic rib fracture is not a big problem. However, there's also nerves. You've got the intercostal nerves, and you can get neuropathic pain, a bit like from thoracotomy pain. So in a theory, if you damage those nerves, you could get a strip of pain where you've treated the chest. But yeah, so there is potential toxicity associated with radiation. I mean, stereotactic's generally very, very safe. It's small volume radiotherapy, so in terms of the general side effects, severe fatigue, lack of energy. It's still a problem, but it's not anywhere near as significant as big volume radiotherapy. Like stage 3 lung cancer, that's a tough gig. That lady I treated, she's done amazing. She's cured from a disease, but she would have had 6 weeks of bad esophagitis, bit of a rough time, mostly out of hospital, but probably 1 in 20 would be admitted for their esophagitis for a few weeks. That can happen. But it's not without, so that's a very important point. It's a great treatment, but like I say, there are some risks involved. But most side effects are transient, last for a week or 2, then settle down, nearly always reversible. Yeah, question there.
Sorry, I was just going to... thank you. What's the difference between radiotherapy and ablation?
Yeah, great question. So radiotherapy is actually the technique that we're delivering, and ablation is what you end up with. So ablation just means the tissue is ablated. So you could do microwave ablation. So I mean, some places stick a needle in, heat the tumor up, and that's a form of ablation. You can do cryotherapy, stick a needle in, but like I say, those techniques are now less favoured because they haven't got as much access to them, and the other thing is they're invasive. So that's another type of ablation, but stereotactic is just a technique to do the ablation. Yeah. So basically, we're given such a high dose, we're ablating the tissue, and that's what the A is in the SABR. Yeah. There's a lady there. Yeah.
I've got a question. Is there a role in radiotherapy for diffuse disease, like the pleura or lepto?
Yeah, another great question. Unfortunately, once you've got involvement of the pleura, just by the nature of it, the cells are all around the pleura, basically. So you might have a pleural metastasis. That won't be the only site of disease because the pleura has got a tiny amount of liquid in it, which allows the lungs to move. It gives you that ability for the lungs to move in and out. It's like a lubricant, if you like. And if you've got cells in there, there'll be cells right the way around the thoracic cavity. So in general, pleural disease is much more difficult to give a curative treatment. However, I get the occasional patient where there is a pleural deposit, it's hot on the PET, everything, there's no pleural effusion associated with it. So sometimes I'll still treat it, but I do warn the patient, it looks as though it's, rather than being on the edge of the lung, it looks as though it's come from the pleura, and they tend to have a less good outlook. Leptomeningeal disease is a really bad overall type picture, because unfortunately, again, the whole cerebrospinal fluid has got tumour cells in. And you'll get various nodularity down the spine. You get nodularity on the leptomeninges, the sort of the lining of the brain. And unfortunately, that has a really poor prognosis. People have given craniospinal radiotherapy. There's publication just the other day, but small numbers of patients. It was a basket trial, so it had breast cancer patients in, lung cancer patients, all different types of cancer in. And they that was actually a proton trial, and they showed some, patients got some benefit, but they weren't comparing like with like. They were comparing it to radiotherapy that was just targeting the little bits of tumour rather than like with like the whole craniospinum. So it wasn't like with like trial. So I think the trial was a poorly designed trial. But yeah, unfortunately, that situation has usually got a poor prognosis. If you present up front with leptomeningeal disease, then obviously these drugs can work amazingly for a period of time. So normally people live weeks rather than years with leptomeningeal disease on relapse. And it's really about, you don't want to cause too many sort of side effects with the treatment. So it's quite a difficult decision to want to give whole brain radiotherapy. I tend not to. I tend to go for a supportive care approach. Yeah. Yeah.
Hi, thanks so much for that really useful talk. I was wondering what your thoughts were on LCT to primary tumours in patients who have otherwise very good systemic control on a TKI who have presented with oligometastatic disease. Because I think there's data that's been published in the EGFR space showing that actually there is an improvement in progression-free survival in that group.
Sorry, LCT, sorry.
So local consolidative therapy.
Oh, right, yeah. So
I'm thinking stereotactic radiotherapy to the primary in a patient who's otherwise systemically very well controlled on a TKI. Yeah,
I mean, again, great question. It's obviously the same with brain lesions up front as well. Are you going to sort of consolidate that? I mean, I'm actually, if you've got a, say if you had a primary tumour and then you had a brain metastasis, I would go for radical treatment to both, up front. So I'd sometimes offer an operation. So you actually resect the primary tumour, as you would do with a lobectomy if they're fit, and then you go after the brain metastasis as well with SRS or surgery. In terms of if you've got more widespread disease, so if you've got multiple Mets, then treating the primary tumour probably going to be less effective. But again, because it's not just the primary tumour that metastasizes, metastasis metastasize. So if you then treat the primary tumour, you've still got the problem with everything else. It's an interesting thing, and that's what the Saron trial did, though. In that trial, it wasn't, it wasn't a driver mutation study, so it's more general lung cancer that we see. But we gave upfront treatment and then with chemoimmunotherapy, and then the patients are randomized to basically treating the primary tumour and the metastases if the primary tumour was radically treatable. So we will get the answer from that study from the non-driver mutation population. But in terms of the driver mutation, because it's a much rarer disease, we can't do these big studies in the same way. But it might inform us to think actually on an individual case basis. The good thing about rarer tumours is it gives you the opportunity to actually say, look, I don't know, but that's, I've got an excuse, let's just do this. It makes sound from oncological principles, that seems reasonable. But multiple disease, I probably wouldn't consolidate. What you could do is give the upfront treatment, and if the primary tumour, everything else shrunk and the primary tumour wasn't doing much and it was causing some obstructive symptoms, you could then consolidate that at that point, but I probably wouldn't do it right up front.
Sorry, I'm just wondering if there's a school of thought that actually within the original primary you have more progressed cell lines potentially, and that you're more likely to develop a cell population that is resistant to your systemic therapy because those cells have been sat there potentially in a more protected environment. Maybe it was the original larger mass, and even if you have good systemic control, that I'm pretty sure there is data that's been published on this, that actually if you just treat the primary, even if it's completely quiet, essentially that you're going to improve progression-free survival.
Yeah, I mean, it's a great question, and then it makes sense sort of theoretically. It's obviously the primary tumour has been there the longest, therefore it's had the most time. It's had the most time to develop further, mutations along the way. But obviously, the successful mutations are the ones that gave it the ability to travel already. So it's those subpopulations that have already been successful in terms of a cancer. And lodging and being able to metastasize in the first place, they've escaped. So it's actually those populations that are clearly the most dangerous populations. In my mind, that would be the case. But yeah, clinical trials are the key way to find out. But yeah, I think if you've got a lot of extra, extrathoracic disease, it probably isn't going to make a lot of difference. It'll be very, very marginal, if at all. That would be my gut feeling. Not to say there isn't some theory behind it, and some preliminary data definitely might been shown to have some benefit, but I think it's got to translate into overall survival benefit and things like that, really, to really change our practice, because it can cause side effects still, the treatment, especially if it's a bulky primary, for example. But yeah, it's a great question, and I'm sure it's individualized approach, and if you're asked that, and I sometimes get asked, why aren't you treating the primary tumour, and I will explain that situation. But I sometimes do treat the primary if it's causing a lot of symptoms. So if they've got bad cough, if they're coughing up blood, then just treat it. Definitely do that way. But yeah, great question. Yeah, you should get on the research team as well.
Thank you so much for this very interesting presentation. So my question is about brain metastasis. So you mentioned that there are some metastases which are not amenable to radiotherapy. So is the technology getting any better to even better target these particular lesions?
Yeah, I mean, so what people are taking on now is just, people are learning more and more and more. But again, you've got to be very careful. There are some centres around the world that they get paid for what they do. So they do some crazy stuff. And again, you've got to really publish this data to show that it actually works. That was, when I showed there was about 34 metastases. So that would happen in the private sector potentially in the UK. There's probably some centres that would do it privately. But in the NHS, I don't think anybody would do that. They've probably got a limit of about 5, most centres. There are various protocols, but people are pushing the boundaries, and we need to listen to these people, and we need to see their research, and we need to see what results they're getting, because actually the side effects of SRS, even if you're treating multiple lesions compared to whole brain radiotherapy, is not too bad actually. People get through it much better than whole brain radiotherapy. Whole brain radiotherapy is not very pleasant, really quite tiring. People feel knackered for weeks afterwards. You know, SRS is a better option. It's not my field. I have to refer up to Newcastle, but they've got more aggressive over the years. So I think the honest answer is, again, it's that individualized approach, which is quite difficult to take, I think, sometimes, because, you know, actually, if you're in a clinic, and it does come down to a bit of potluck, doesn't it? And that's why people feel it's difficult sometimes, thinking, well, should I push this agenda with the consultant? People, you know, don't like challenging consultants, and you should do, okay? You should ask. Most people are open, and if they're not very good doctors, okay? You have to listen to what people are saying, and if you know, if there isn't the evidence base, it's fair enough not to offer the treatment. But yeah, I think we will be treating more metastases as time goes by, but to be honest, if you look at the data, it's pretty marginal, very marginal benefits when you've got that much disease. It really is small. We're really going to make breakthroughs when the new drugs come along to you know, deal with the new mutations that are developing. It's going to be a systemic problem to, you know, a systemic solution to a systemic problem. We're just doing a little bit of you know, patching up where we can, but ultimately that isn't going to be the answer. The answer is in systemic therapy and, you know, the next generation, 4th, 5th generation ALK inhibitors. And those sorts of drugs are going to make the difference, I think. Yeah.
Yeah, probably I meant more like location.
Oh yeah, and that would come down to the SRS specialist, because in location-wise, if it's in a very eloquent area, although we can be very accurate within like a millimetre or two, if they've already got symptoms, if they've got speech problems, you can make that speech worse, etc. So they'll have those conversations, and again, it might come down to, you know, are you prepared to take this risk, you know? And I do have those conversations with patients when I'm treating other parts of the body. Look, I could cause you damage, I could shorten your life expectancy, but I think on average, I think the benefits slightly outweigh the risks. But we really have these very difficult conversations sometimes, think, actually, I could do you some serious damage, and whatever time you've got left, I actually might make it worse for you. And the key thing is us just be honest about that. But then you can, you know, if the patient wants to go for it, you just go through it together and say, look, if you do become poorly, we'll keep you comfortable and peaceful. You know, you have to have these honest conversations. But yeah, but it's fantastic to see, and we can do a lot more than we used to. It really is encouraging. But definitely getting better. Yeah, absolutely. It's, grounds for optimism. Absolutely.
That's a great note to finish on.
Thanks very much, Deborah.
I think all of us would like to thank Clive for coming along today.
Thank you so much.
It's a small appreciation.
Oh, lovely. Cheers.
Very, very small.
Thank you.
So, hopefully Clive will be able to join us for lunch, maybe? Or have you got to drive off?
Yeah, I'll probably drive up. I've got
Okay.
about a 6-hour drive up to Yorkshire.
You have actually, yes.
I love driving though, it's all right.
That's okay then.
And it's a real pleasure to come down. Thank you so much. And it's
No,
an
thank
amazing
you.
crowd you've got here. It's brilliant, isn't it? And let's hope it gets bigger and bigger every year.
Absolutely.
Come on.
Yeah, okay.
Fantastic.
There you are.